Muchas gracias, Josep. And I will not give my talk in French, although we're in Paris, and I welcome you all to Paris, although the weather could be better than it is. It's a pleasure to give this talk this afternoon. And the topic that I was asked to address is an interesting one: how to choose between oral PrEP and intramuscular PrEP now that we have the options to do that. So these are my disclosures. And since David was ahead of time, then I have maybe more time to deliver my talk, so that's great. First, I thought I would start by, trying to summarize what would be the features of an ideal PrEP regimen. Clearly, what people expect is a regimen with an effectiveness that would be near 100% when taken as recommended, and a regimen that would work not only for MSM but also for heterosexual men and women, IVDU, adolescents, pregnant women. The ideal PrEP regimen would be a regimen with simple adherence, with high forgiveness, and that's why long-acting formulations are interesting. We probably also need clear guidance on how to start and stop PrEP for each regimen, and maybe here with cabotegravir we don't quite well know how to start PrEP. We also need, I think, a simple assessment of adherence so that we could tell when we see the patients whether or not he was adherent to his regimen in the weeks prior to the visit. Another important attribute of the ideal PrEP regimen would be to make a rapid and simple diagnosis of breakthrough infections. That's obviously critical to avoid transmission of HIV, especially if breakthrough HIV infection are associated with the emergence of resistance, and we want to avoid this potential dissemination of resistance among PrEP users. In terms of safety and tolerability, the bar is also high because we're dealing with healthy individuals, and we need a regimen with almost perfect safety and ideally without need for safety monitoring. We don't want to do creatinine every other day, etc. And finally, in terms of implementation, we want to have something easy to use, self-administered, at an affordable cost, and also ideally which would be able to combine prevention of HIV and also conception, and why not STIs. So clearly we don't have this regimen available today, but that would be the goal eventually. And to give you an idea of where we stand regarding PrEP implementation worldwide, this is the AVAC tracker, which gives you every trimester the number of people having initiated PrEP worldwide, and you could see that now it's nearly 2 million of people who have started PrEP. It's still low, but it's increasing nicely. And you can see the countries where PrEP is implemented, and mainly America, Europe, and Africa, as well as Australia and Brazil. And it's amazing to see that it's actually in Africa where you have the highest number of people using PrEP today. So in order to make a choice between oral PrEP and intramuscular PrEP, I think it's important to briefly review the data we have with oral PrEP and intramuscular cabotegravir. So just a reminder of daily PrEP with TDF-FTC among MSM in the UK, the PROUD study, where you could see that among these MSM randomized to either immediate PrEP or PrEP after a year, the incidence of HIV infection in the deferred arm was as high as 9%, very high incidence. That was back to 2014, 2015. And with immediate PrEP, the incidence decreased to 1.2%, with an effectiveness which was 86%, so very high effectiveness. And so when daily PrEP is taken almost perfectly, then the effectiveness could be as high as 86%. Using the same drugs, TDF-FTC, but event-driven with on-demand PrEP in the same population of MSM at the same time, in the years 2012 to 2015. In France and Canada, you could see that the incidence in the placebo arm overall was 6.6%. It declined to 0.9% during the double-blind phase with on-demand TDF-FTC, which was also an 86% relative reduction of HIV incidence. And during the open-label phase, the incidence dropped to 0.19%, with a 97% relative reduction of HIV incidence. And indeed, in this trial, the few HIV infections we've seen were documented in people who have not used PrEP at all. And it's important to focus on the incidence here. 0.19 with on-demand PrEP among MSM in France and Canada in the open-label phase. We will publish soon the cohort that we have started in Paris in 2017, looking at individuals who were mostly MSM, actually 97% were MSM, who started PrEP in 2017 and were followed overall for 3 years, so the mean follow-up per individual was 22 months. And during this prospective cohort study, people could actually choose between daily TDF-FTC or on-demand TDF-FTC. Most of them used actually generic tenofovir-FTC. And what's interesting here is when you look at the bottom table, you could see that the HIV incidence per 100 person years of follow-up was 0.12, whether people used daily or on-demand PrEP. So very similar effectiveness. So this is consistent with the data we had from IPERGAY and the PROUD study. When you use the TDF-FTC, whether it's on-demand or daily, you have the same effectiveness. And what's interesting here is that the global HIV incidence was 0.11 per 100 person years, so even lower than the incidence we've seen in the open-label extension phase of the IPERGAY study. So this is a very low incidence. Only 6 cases of breakthrough infections were seen. Only one of them had the M184V mutation. There was an individual who actually stopped PrEP and then resumed PrEP without testing for HIV, and that's the reason probably he acquired this M184V mutation. So this is the number I'd like you to remember, an incidence of 0.11 per 100 person years with oral PrEP among MSM in France. So what's the issue with PrEP is actually adherence with especially oral PrEP. And in this graph from the Discover study was a large randomized trial among MSM comparing daily TDF-FTC to daily TAF-FTC. And if you focus on breakthrough infections in individuals randomized to the TDF-FTC arm, you could see that when you looked at tenofovir diphosphate level in dry blood spots, and you look at the HIV cases, you could see that the concentration of tenofovir diphosphate was consistent with less than 2 doses of TDF-FTC per week. So clearly less than 7 doses per week, as compared to, in a case-controlled study, HIV negative control, so people who remain on PrEP and remain uninfected, where the median concentrations were consistent with at least 4 doses of TDF-FTC per week. And we know that with daily PrEP, to be protected from HIV, you need to take at least 4 doses per week. And when you look at this table showing the risk of selection of drug resistance when you fail PrEP with TDF-FTC, you could see that there are 2 different situations. In the right column, when people seroconvert weeks after PrEP initiation, so months after PrEP initiation, you could see that the risk of resistance at the bottom row is only 3% of selecting resistance to TDF or mostly FTC actually. And this is because when people seroconvert using PrEP, it's because they didn't take PrEP. And if they didn't take PrEP, there is no reason that you would select for resistance. On the other hand, in the middle row, in the middle column, when people are infected with HIV before starting PrEP, when acute HIV infection is not diagnosed at the time you start PrEP, then because you're starting a dual combination in someone already infected, the risk of selecting M1T4V is much higher, 48%. That's why it's so important with PrEP to rule out HIV infection before starting PrEP, or at least be able to diagnose HIV infection very early after PrEP initiation. What's the overall safety of PrEP? And this is a table from the Discover study comparing daily TDF-FTC to daily FTAF. And you can see overall that the rate of study drug-related adverse events was quite low, 21% versus 24%, and this was actually similar with FTDF and FTAF. And mostly these study drug-related adverse events were mostly gastrointestinal adverse events. When you look at serious adverse events, which were drug-related, you can see that the proportion is 0.1% or 0.2% with FTDF. So very, again, similar. And very few adverse events led to study drug discontinuation, 1% with FTAF, 2% with FTDF. And these results are important to keep in mind when you have to make a choice between FTDF and FTAF, because obviously one drug is available as a generic, the other one is not. And clearly, it's interesting to look at the renal safety of both strategies. And you have here the changes over time from baseline in EGFR. And you can see that in red with FTDF, after 2 years, the median change is almost zero, minus 0.4. This median change is higher with FTAF, so it's better to increase the EGFR, but it's a minimal increase. It is statistically significant, but it has no clinical relevance. And when you look at something which has more clinical relevance, the number of people who discontinue PrEP for renal events, only 2 individuals with FTAF and 6 with FTDF discontinue out of 5,000 individuals followed for 2 years. So this is quite reassuring in terms of the safety of PrEP in healthy individuals, and only a single individual out of 5,000 people actually developed a Fanconi syndrome after more than a year of PrEP. Similarly, when you look at bone mineral density, again, there is a statistically significant difference between FTAF in green and FTDF in gray, favoring FTAF. But again, the difference is not that large. It's overall less than 2%. And actually, even with FTDF, the decline in bone mineral density levels off over time. And so that might be a reason in people at risk for osteoporosis or with osteopenia to prefer to use FTAF. But other than that, the risk is really limited, and there is no need to monitor bone mineral density in someone on FTDF as long as there are no risk factor for osteoporosis. So what are the limitations of oral PrEP today? I tried to list a couple of limitations. First, the stigma associated with pill intake. This stigma still exists, and some people might prefer to use a PrEP regimen that would be not noticeable. Gastrointestinal adverse events with any oral drug, you will have a risk of nausea, potentially diarrhea, that could be sometimes bothering, especially with on-demand PrEP. It seems like you have a pretty significant rate of gastrointestinal adverse events that usually disappear over time, but still. We don't have data with TAF-FTC in women. There are trials ongoing. We don't have data with on-demand TAF-FTC. A trial is also planned. The cost is an issue with TAF-FTC because the cost of the drug would be 300 euros per month, whereas with generic TDF-FTC, especially if you buy the drug in hospital in Paris, it's 10 euros per month. So this is a quite significant difference. But I guess the main limitation with oral PrEP is the issue of long-term adherence to pills, whether it's daily or on-demand pills. Some people are tired of taking pills or over time, and that might be clearly a place where intramuscular long-acting agents could have a role. And I like to show these slides to make the parallel between PrEP for HIV and contraceptive methods. And what you see on the graph is the probability of pregnancy, so of failure of contraception, according to the method used. So at the bottom of the graph, you have abstinence, just above withdrawal, so we know it's not that effective for contraception. Mild condoms in light blue, and in pink it's the pill. And you see that for pregnancies, you have the same probability of pregnancies whether you use a condom or a pill for avoiding pregnancies. But then with injectable agents, you can see in blue that the rate of pregnancy is much lower. It's even lower in green with the implants. And I think with HIV prevention, it's going to be probably the same. If you could use an implant or injectable agents, you may end up with a higher effectiveness. Higher effectiveness doesn't mean higher efficacy, and that's what I'm going to show you now. David showed you the result of the 2 HPTN trial with cabotegravir, and I think it's important to remind that in these 2 trials, the study design was a double-blind, double-placebo randomized trial. So people were all receiving injections, and between visits, they were giving pills, or boxes of pills, and they were asking to take the pills. But everyone received the injection without knowing whether they received a placebo or cabotegravir. So you have to understand that people, all of them, most of them, thought they were receiving the injection and PrEP. And you are in the best position to reduce adherence to daily pill, because why taking pills since you just received an injection? Of course, you're not sure, but you would bet, well, I probably received the injection. And that's why when you look at the incidence, here we are among women, you see with TDF-FTC, the incidence in red is 1.8 per 100 person years, which is 10-fold higher than what we've seen among gay men in France. And even with cabotegravir, where the incidence is only 0.2, it's still higher than the incidence we've seen among MSM with oral PrEP. So of course, here we are talking about effectiveness, and this is driven clearly by adherence. For cabotegravir coverage, of course, after a year, cabotegravir coverage is higher than 90%, but it's also because women were paid to attend visits to receive cabotegravir injections. They were not paid to receive the pills. And you can see that over time, the plasma tenofovir concentration dropped, and at the end of a year, less than a third of women were taking daily PrEP. So no wonder that you see a difference in incidence, but it's driven mainly by adherence, not by the efficacy of the 2 regimens. And the same is true with MSM, where in the HPTN 083 trial, look at the incidence with TDF-FTC, 1.2 per 100 person years, 10-fold higher than the incidence we have in the same population of MSM in France using TDF-FTC. It's the same incidence also that was reported in Australia with oral TDF-FTC. So again, adherence here plays a major role in explaining the results, and clearly that's why the effectiveness of cabotegravir is higher, even though the incidence here with cabotegravir is 0.4, much higher than the incidence we've seen with oral TDF-FTC among MSM in Paris with oral PrEP. And if you look at the incidence of HIV infection during the open label phase in HPTN 083, you could see that with cabotegravir it increased from 0.4 to almost 8, which is quite a double in the twofold increase in the incidence of HIV. And the same is true with TDF-FTC. The incidence is 2.2, which is a very high incidence in someone using or not using PrEP, actually. In addition, as David mentioned, in people who failed cabotegravir despite receiving their injection at the right time, I'm not talking about those who missed the injection. Still, a few developed HIV infection, and HIV infection, in addition with the emergence of cabotegravir resistance, which in some instance could be cross-resistant to dolutegravir. And at CROI, they presented data in those individuals, and the mutation can be detected very early, even in those with less than 200 copies per ml at the time the first occurrence of HIV infection. So that's a concern, a major concern, and the CDC now has recommended with cabotegravir that people would be monitored by HIV RNA in addition to HIV serology, which is an issue for developing countries if they want to implement cabotegravir. How they're going to do that if they have to do an HIV RNA test at every visit. They cannot do that for the monitoring of HIV infection already. Another issue with cabotegravir is the delayed diagnosis of breakthrough HIV infection. And in this case, for example, the HIV infection was diagnosed on site more than 16 weeks after it was diagnosed retrospectively on store samples. And overall, in the study, they could measure the delay of diagnosis with oral TDF-FTC, which was 30 days, a month, whereas it was at least 2 months with cabotegravir when you talk about baseline infection, but it could be up to 3 months with cases, incident cases, because with cabotegravir you maintain high concentration of drugs, and therefore the viral load is low and the antibodies appear later. And that's why it's so difficult to make the diagnosis. So these are issues that we have to keep in mind when we discuss the pros and cons of oral versus intramuscular cabotegravir. In addition, with cabotegravir, you have injection site reactions, although in the studies, only 2% of the individuals actually discontinued cabotegravir because of injection site reaction. So there are a number of limitations with cabotegravir at this point. The burden of 2 monthly injections. It's not self-administered, you have to find a nurse to do that. The lead-in phase and the tail coverage. Today, we think we can get rid of the lead-in phase. Tail coverage, we don't know enough yet. There is an unknown time to protection and forgiveness with cabotegravir at this point for PrEP. Injection site reaction, we mentioned them. I think one limitation is the emergence of INSTI resistance with potential cross-resistance to dolutegravir. And in addition to that, the dissemination of INSTI resistance in those individuals. In people using PrEP, they usually have sex together. If you have someone with resistance to cabotegravir emerging, and if this resistance can disseminate to the other guys in the group, then you may have a problem with a number of breakthrough infections. The cost could be also an issue. And I think for individuals, when they have to make a choice, well, although it's a rare event, they still have instances where breakthrough infection can occur despite the correct use of cabotegravir for PrEP. And this situation is very, very rare with TDF-FTC, with oral PrEP. We only have a handful of cases where people were supposed to have had HIV infection when they were fully adherent to their PrEP regimen. So in summary, I think we don't have yet the ideal PrEP agent. I think oral PrEP remains highly cost-effective and effective. And at this point, I would use cabotegravir only for people who have issues to adhere to oral PrEP. And anyway, I think the more choice we have, the better for people. And clearly, the most effective PrEP agent is the one people use for PrEP. And with that, I thank you for your attention.